Ultrasound imaging stands as a frontline tool in the evaluation of gallbladder conditions, particularly when it comes to the identification of multiple gallbladder polyps. These polyps present as small, echogenic lesions ranging from 4 to 5 millimeters, securely anchored to the gallbladder wall. Unlike gallstones, these polyps remain stationary, regardless of changes in patient positioning. This immobility is a critical distinguishing feature, as the acoustic shadowing characteristic of stones is absent, allowing radiologists to make confident assessments. Furthermore, when color Doppler imaging is employed, it reveals minimal to no vascularity within these polyps, reinforcing their benign nature, while the gallbladder wall remains unremarkable with no signs of inflammation. Such findings often indicate incidental polyps in asymptomatic individuals, emphasizing the importance of careful ultrasound interpretation. Differentiating gallbladder polyps from sludge is essential in clinical practice, as it directly impacts patient management. Gallbladder sludge, distinct from polyps, appears as low-level echogenic material that is mobile, tending to settle in the dependent area of the gallbladder. This mobility is a hallmark trait. When the patient changes position, the sludge shifts, whereas the polyps remain steadfastly affixed. Another notable distinction lies in their morphology. Sludge lacks a definite shape, while polyps are characterized by well-defined nodular forms. Doppler imaging supports this differentiation, typically showing no internal vascularity in sludge, albeit some adenomatous polyps may demonstrate vascularity, heightening the need for further investigation. Considering the differential diagnosis is paramount when evaluating gallbladder polyps, cholesterol polyps stand out as the most prevalent type, generally benign and arising from cholesterol-laden macrophages. In contrast, adenomatous polyps present a neoplastic concern, particularly when exceeding 5 millimeters, with a malignant potential if they reach 10 millimeters. Inflammatory polyps, linked to chronic cholecystitis, manifest without vascularity, but may be accompanied by gallbladder wall thickening. Notable mentions include adenomyosis, which presents a thickened gallbladder wall, and early gallbladder carcinoma, which poses a risk if the polyp exceeds 10 millimeters and exhibits irregularities or vascularity. Management and follow-up protocols vary depending on polyp sizes. Lesions measuring 6 millimeters or less necessitate follow-up ultrasounds within 6 to 12 months to monitor changes. However, polyps measuring 10 millimeters or more elevate concerns regarding malignancy, prompting considerations for cholecystectomy. Irregular, vascular, or growing polyps warrant additional imaging such as MRI or MRCP, or even a surgical consultation. In contrast, gallbladder sludge generally requires no routine follow-up, relegating attention to cases presenting with symptoms or wall thickening, thereby ensuring a balance between conservative monitoring of benign findings and prompt intervention for potentially hazardous lesions.